Good afternoon, all. A very happy new year for all the faculties and my professors there. Today I'm going to discuss on a topic I felt, which I didn't feel as a common topic when I was doing my residency. But after coming to Jaikumar, I felt it is a disease which is existent, and probably we have to be more vigilant about this disease. So the unsuspected offender. I have nothing to disclose. So basically, Kawasaki disease was one which was not that commonly suspected during my UG days. Then it came as probably a suspected disease when there was a fever for an unknown origin. And now probably in the last 2 years of my JIPmership year, we have found many common symptoms or many common presentations. At the end of the day, were not like common diseases like URA or pneumonia or viral hepatitis, but at the end of the day, it turned out to be Kawasaki disease. So I'll just give you certain cases what we have seen in the last 2 years, where we have actually Googled, or like we found it was like a totally different diagnosis what we reached at the end of our evaluation. So case number 1, actually this was a 3-month-old infant, but actually had come to us with complaints of fever for 2 days, and there was abdominal distension and bilious vomiting for 2 days, and child was actually actively febrile. The temperature was mounting to 103 and 104, and child was having a tender abdomen with reduced bowel sounds, and bilious aspirate was found in the NG tube. So generally, when we have this sort of a scenario, we usually think of either a systemic sepsis or a surgical abdomen. And that's what we also suspect in this patient. Maybe he's having a systemic sepsis or a perforation peritonitis or a surgical abdomen which has gone for a peritonitis complication. Or one thing which we commonly see or suspect is Wassermann-induced enterocolitis. And the X-ray of abdomen showed no air under diaphragm, predominantly a dilated bowel loop with mild thickening of the bowel wall and centrally placed bowel loops. So we initially thought, okay, we'll treat it as a gram-negative sepsis. We gave the child supportive antibiotics and we waited. Despite 48 hours or 70 hours of antibiotics, there was no response in terms of the abdomen status, no response in terms of fever status. The child was having persistent fever of 103 and 104. So we were actually puzzled what to do. So this was a presentation like a surgical abdomen in a 3-month-old infant. Another case, an 18-month-old toddler who had come with like high-grade fever, again 103, 104, child has having fast breathing, and there is history of cough and cold for the last 2 days. On examination, child was not toxic. Child was having fast breathing with chest indrawing, and there was bilateral diffuse crepitation, and SpO2 in the room air was 84%, and with oxygen supplementation of 97%. And the X-ray was typical viral pneumonia like picture, like the hyperinflation, bilateral diffuse, reticular infiltrates. So again, we thought of, okay, this could be a bronchopneumonia, maybe a viral pneumonia, because the child was not that toxic, maybe okay, a chlamydial or mycoplasma pneumonia as well. Again, this year also we started supportive therapy along with azithromycin. There was no response after 3 days. Child was persistently oxygen dependent, child was having persistent distress, and fevers are still mounting to 103 and 104. So this is another presentation like a respiratory infection in this case, and still we are puzzled at the end of 3 days of our hospital stay. Still we are not having a clue on what to do. This is the third case, a 10-month-old child who's coming with fever for 4 days. Child is having refusal to feed or play, and there is persistent inconsolable cry, and there are no localizing signs. Again, the child was having high-grade fever. So persistent inconsolable cry and fever, we are going to think of say meningitis or buccal bacteremia or an otitis media. So again, we are doing LP. LP is totally normal. Autoscopy examination done, that is normal. So we are still clueless. Okay, as a suspicion of buccal bacteremia, urine microscopy was done, and there are plenty of pus cells. Okay, we are taking this diagnosis as UTI. We started on IV antibodies, IV amikacin. Child is not showing a response in terms of fever, irritability, and there is persistent fever. Again, here we are puzzled. Okay, we have a case whom we are suspecting as UTI, but still not responding to UTI therapy. Urine culture came still. So here also we are puzzled what to do next. This is a 16-month-old toddler who is coming with the fever for 3 days, and there is parotid gland swelling for 1 day, and there is no other localizing signs. Obviously, in this age group, we are going to think of a viral parotitis, maybe mumps, because child was having high-grade fever. We thought, okay, maybe a suppurative parotitis. So we're getting an ultrasound done. There are no signs of any collection inside. The child is having persistent fever. The parotid swelling is persisting even after 7 days of illness, and fever is not responding. So here again, we are puzzled. Okay, what is this? We have a child whom we are having parotitis, but fever is not responding. So again, this is one other presentation where we are not having an answer at the end of 7 days of illness. There's another case, an 18 months old toddler who is coming with complaints of fever for 2 days, and on day 2 of fever, an episode of GTCS for 2-3 minutes with active fever. And after the seizure has settled, child is having normal sensorium, no meningeal signs, no focal visit. Obviously, we'll be thinking of febrile seizures here. So we're thinking of febrile seizures. We just want to observe. Child is neurologically doing well, but child is having persistent fever. 2 days or 3 days of hospital stay, fever is not still coming down. We have done all possible investigations. Even CSF was done, that was normal. Urine microscopy was done. So we are not getting any clues in this given case who's having seizures and fever. So we are not sure what is this case. So now case 6, actually a 17 months old toddler who is coming with complaints of fever for 6 days. There is jaundice and high calorie for 2 days. Child is icteric and febrile, and child is having liver of 4 centimeters. Despite onset of jaundice, there are still persistent fever. We thought, okay, a typical tropical infection, maybe strep typhus, enteric or leptospira. So we are evaluating for that and we are treating for that, not responding. So after 3 days of hospital stay also, there was no response and there was worsening jaundice only. So because there was worsened fever and probably the child was having a liver, we thought, okay, maybe why not an HLH, probably because of an infection. Evaluation for HLH done, classical criteria satisfied. So child is having the criteria of HLH satisfied, child is having fever. So what is a trigger for this HLH? So that we are not having a clue. Are we dealing with this child as a primary HLH? So those are the two questions which are there. So then we got another clue, which I'll be discussing down the line. Case 7, we have a child who is presenting with high-grade fever for 6 days. Child is having irritability, and child is observed to have right-side hemiparesis and right-sided upper motor neuron facial palsy. So we are doing an imaging that is showing a left gangliocapsular infarct. Okay, we are taking it as probably a pyogenic meningitis partially treated, or maybe a tuberculous meningitis. CSF was showing predominantly lymphocytic pleocytosis and protein was slightly elevated. So we are taking it as probably a partially treated pyogenic meningitis or a tuberculous meningitis. Child has been given therapy despite 3 to 4 days of antibiotics, no response. Evaluation for TB, totally nothing is coming out. There is no contact with tuberculosis, and child is having persistence of fever, and child is having the focal visit persistently there. So repeat imaging also we planned, okay, maybe it is still tuberculous meningitis. Maybe we are getting any other imaging findings. We are doing that. I'll discuss this case again down the line. So the last case was probably a meningitis. Still, we are not able to figure out what is that. And the next case was a 11 months old infant who is presenting with fever with rash for 4 days, and child is having fast breathing, poor feeding for 2 days, and reduced on food for the last 1 day. On examination, child is having generalized maculopapular rash with mucosal congestion, a gallop rhythm, enlarged liver, bilateral crepes. So a child with an acute febrile myocarditis. So clinically, because child had rash, we thought of, okay, maybe an enteroviral myocarditis, or maybe a scrub typhus induced myocarditis, or at the end of the day, maybe a bacterial septicemia, probably meningococemia, which is presenting as myocardial dysfunction. So child was given supportive therapy and antibiotics, as well as anti-scrub like doxycycline was also given. Child is showing no response in terms of fever, and child is having persistence of this dysfunction needing inotropic support. So these were the 8 different ways. We had a case where we are not able to get a clear-cut response or improvement despite 3 to 4 days of therapy. So all of the above cases were like a routine case, what you see in any pediatric unit, where you first think of an infectious etiology. All cases we are given an appropriate support therapy and antibiotics, but we are finding no response. We are clueless after 3 to 4 days of hospital stay. Still, we are not able to progress in any direction. And what does the investigation all show? At presentation, the investigation was practically not giving any other clues, because the child was having persistence of symptoms. Maybe another 3 or 4 days down the line into the hospital stay, again the investigations were repeated. And majority of the cases, the investigation was showing anemia, neutropenic leukocytosis, either a high normal platelet count, something like 4.5 lakhs, or sometimes even thrombocytosis. And the child was showing persistently like albumin around the borders, like 3.2 grams, or sometimes even 2.8 grams. So low normal albumin or low albumin. And similarly, AST somewhere between 30 and then somewhere rising up to maybe 60s to 70s. So this is what we have at the end of 4 to 5 days of our hospital stay, which is going to be day 5 to day 8 of the hospital illness. Again, now to disregard these investigations as a routine thing. Say in India, where 60% are anemic. So anemia with high normal thrombocytes are obviously going to be thought of iron-deficiency anemia. A patient is having neutropenic leukocytosis. Obviously, you think of an active infection which you are not able to figure out. You're thinking of resistance or thinking of some other localized problems. So you're thinking this neutroglycoside is because of the active infection. And obviously low albumin, all those things as a part of, as a malnourishment or a negative acute phase reactant, where malnutrition is common in India, almost 30%. And there's elevated AST, ALT as a part of topical infection. So this, if we can interpret this as in this direction, still we will be clueless. Okay, we thought, okay, should we think in a different angle? We thought of all common infections and we are still not able to get, so should we think in a different angle? So that's where we had a discussion ourselves. And then the one common thing which is common to all these cases where persistent high grade fever, 103, 104 not responding. We generally don't see a temperatures of 104, 105 unless until there is any suppuration somewhere. And all of these were in the age group of less than 3 years, infancy and toddler age group, and were all showing this sort of progressive rise in thrombocyte count, persistent neutroglycosidosis, progressive rise in AST, gradual fall in albumin, and anemia. So this is where we all put together, we thought, okay, why not Kawasaki disease? So all these cases never gave one of these classical clues. Generally, Kawasaki disease is where we think of rashes as the predominant symptom. The classical Kawasaki is actually only 30 or 40% of what we see. Predominantly, what we see is incomplete Kawasaki disease, where these criteria are not satisfied. So classical Kawasaki is where you have to have 4 of these criteria: a mucosal rash in the oral mucosa, a rash in the conjunctive skin, a congenital suffusion, and peripheral extremity changes in terms of edema, peeling, and lymphadenopathy. Majority of the cases what I've described, none of them are showed the classical findings. So in our experience in the last 2 years, we have seen close to 30 cases. Almost 50% of these cases never had these findings during hospital stay. So these are the classical findings of a congenital suffusion, oral rash, mucosal tongue rash, and the patient is having edema, peeling. So none of these findings were there in 50% of these cases. But again, this is what the criteria also says. Many times you have to go back, ask if they have those lesions at home. So when they present to us, those lesions would have resolved, or they may develop during the hospital stay. So at presentation, they may not be there, but always we have to probe whether those things were present in the past to them, or we have to anticipate whether those things are developing in them. So how then to work up a case of incomplete Kawasaki disease? Obviously, you'll do a CRP and ESR, and these are the 6 parameters which we have to do: HB, platelet counts, albumin, ALT, WBC count, and urine microscopy. So why to identify incomplete Kawasaki disease? This is more common and it is more difficult to identify. And more early you identify these patients, better you prevent them from developing a coronary artery abnormality. And majority of these cases are associated with coronary artery abnormality. So what happened to our cases? So our case number 1 was having that intestinal obstruction like feature. When we look closely, we found that patient was having this BCG site erythema. This picture is actually the heel BCG site where we are having only the hyperpigmentation 95. The patient was having, on close look, then we found this patient was having erythema. So from there we started, okay, why not a Kawasaki disease? We got an echo done, and the echo was showing an aneurysm in the left main coronary artery and right coronary artery. And this image you can see the left anti-descending artery, there is no tapering of the vessels. The vessels are almost in the same size. So it's just not aneurysm which should be present. Even failure of the coronary arteries to taper, presence of a pericardial effusion, myocardial dysfunction, valvular regurgitation, or aortic root dilatation. So these could be a manifestation of Kawasaki disease. So in our patient, we had aneurysm and failure of tapering. So then we cracked, okay, this is a case of Kawasaki disease which has presented with intestinal obstruction like feature. Case number 2, the child was having persistent fever, the child was not responding to antibiotics. Okay, so then what we did? So we just had a CBC which are showing slightly worsening platelet counts and worsening enzyme levels and falling albumin. There was a trend towards Kawasaki disease. Okay, then we thought, okay, why not a Kawasaki disease presenting as a pulmonary disease? We gave IVIG and the patient showed a good deference and patient became distress-free. So this was a very challenging case for us where we had no clues and we just had to shoot at the dark, where we had a typical LRI who's not responding. The case number 3 who was having typical UTA-like features in terms of urine microscopy, and child was having persistent fever and irritability. So we had no clues, but again, the same, the worsening trends of acute phase reactants was present. And on day 7, we got an echo done, which was showing coronary artery aneurysm. So we treated this patient on day 7. Again, the point I would like to stress here is we allowed the patient to develop coronary aneurysm. Had we been more vigilant, probably we could have prevented this. So that is what is the ultimate objective of identifying a Kawasaki disease before they develop an aneurysm. The case number 4 was having that persistent parotitis. So again, this patient was having no suppuration. So this child was showing the typical worsening trend of acute phase reactant. The AHA criteria for the incomplete Kawasaki disease is satisfied. We again treated this child with IVIG. This child was responding very well and the parotitis improved. We are lucky enough to prevent this patient from developing a coronary aneurysm. And the case number 5 was having that febrile seizures. So on day 3 or 4 of the fever, child was starting to show the classical rash. So then we cracked and this child was in case of Kawasaki disease. So at presentation, there was no rash, but during the hospital stay, the child showed rash. So it may not be present at presentation, but may develop later. Case number 6 was having the criteria satisfied for the HLH. This child was having persistent fever. There was no consanguinity in the family. So chance of this child being a primary HLH was low, but still not ruled out. The child was having persistent fever. So we had no choice, but we just, as a part of screening, we just did an echo that was showing a coronary aneurysm. So from there, we diagnosed this patient as having Kawasaki disease. So Kawasaki disease can present as acute hepatitis and with macrophage activation syndrome as well. So whenever you have a child who is having something like an HLH or macrophage activation syndrome, think of Kawasaki disease. That could be a Kawasaki disease as well. Probably this child was, if like 2 or 3 months, maybe you will not have thought of even to do an echo, you would have thought of primary HLH. Since this child was around 18, 19 months, not a classical age for a primary HLH, that's where we did an echo. So think of Kawasaki disease when you have an acute febrile hepatitis, not responding to your routine therapy, not able to find an answer, go for an echo. Case number 7, where we are thinking of partially treated meningitis, no response to antibiotics, TB violation, totally non-contributory. Okay, we are having person fever, going for repeat MRI. There was no basal X-rays, no hydrocephalus. By and large, in TB meningitis, some basal X-rays will come after day 11, day 12 of illness. And one important finding was like sensorium was relatively well preserved. And again, this patient was showing a progressive worsening trend of acute phase reactant. So we got an echo done on day 14 showing an aneurysm. So again, this case, we have missed the bus. It was too late by the time we diagnosed, but still at least diagnosed on day 14 of illness. And case number 8, where the patient had presented with a typical myocardial dysfunction, all the evaluation for tropical infections came negative, intraoral PCR came negative, so you're still clueless. Again, the acute phase reactant was showing a worsening trend, and echo on day 7 was showing a coronary artery aneurysm. So Kawasaki disease can present as myocardial dysfunction. So as புரட்சிக்கவி பாரதியார் சொல்ற மாதிரி இனி ஒரு விதி செய்வோம். So the one general thing what we right now in our department do, whenever we have a patient who has a typical infection like presentation, but he is not showing any response to routine therapy, he is of an infantile or toddler age group, the fever is like 103, 104, and one important finding, we are finding irritability. We always inspect the BCG site, we inspect the perineum, because that will be the first thing that rash will be starting from. And always we probe the history again, was there any rash present or not? And we give a lot of emphasis on this markers which are worsening. So generally on day 3 or day 4, we repeat the markers again to see if they are showing the worsening trend. If the moment they are showing worsening trend, we really suspect a Kawasaki disease. We straight away go for an echo. Most times we have got it right. So Kawasaki disease is still common, and incomplete disease is more common than the complete form what we routinely think of. Don't wait for the criteria to be satisfied. Like many times the platelet count should be more than 4.5 lakhs. You may not reach that 4.5 lakhs, but you'll see the trend. At presentation, the platelets should have been only 2.5 lakhs. But on day 3, day 4 of hospital stay, you'll find the values rising towards 4 lakhs, 4.5 lakhs. So worsening trend also should alert you. And always when you're suspecting that, go for an echo. Many times you'll get a lot of clues from that. And obviously this criteria is still evolving, and newer specific laboratory markers are on the rise, on which will give a more confident answers for us. And obviously it is important to go for early treatment, because it is very important to prevent a coronary aneurysm developing, because it has long-term sequelae. And this is Professor Tomisaku Kawasaki in his first Sentinel Preston paper in 1967. We are now 50 years from that description, and almost 40 years from the first case report in India in 1977. Thank you for your patient listening.
Thank you, Dr. Jaikumar. There are a few topics which we can say eye-opener. So I would definitely say this was an eye-opener for me. Like this is a common scenario we all come across. So thank you, Jaikumar, for your eye-opener topic. Sir, Madhavan sir.
I think it's nice to hear Jaikumar, and 2 months back, we were in touch with Arun Gopalakrishnan, who's in Sri Chitra, and also Avinash, who's in Jipmar. I think the same picture had been emphasized by them also. And is there any overlap with Corona picture, Jaikumar?
So what our case discuss is all like the pre-corona, sir. Right now, after the onset of corona, we are definitely had a significant surge. In the last 8 months of our tenure, like we had almost 15 to 18 cases of MASC, where majority have significant rashes. The classical thing, both in MASC